for the introduction and of course for the invitation. It's my pleasure to present, and it's based on the talk I gave this fall, and then the audience was a bit different, of course, was mainly pathologists, some industry. So it's always nice to present this for colleagues as well. So I would like to show to you an overview of biomarkers and targeted treatment options in standard of care and emergent treatment options for subgroups of colorectal cancer in the clinic. So this is my disclosures. So I will discuss today how we can move towards optimal patient selection for treatment. What are the clinical relevant subgroups, and what are targeted treatment options for these subgroups, and what are novel biomarkers in development, which can help us in achieving our goal to optimal select patients for treatment. So colorectal cancer is actually quite a heterogeneous disease, and it's not one disease, but you should really look at it at different subgroups. Of course, DNA mutations are responsible for important subgroups, and then it's mainly RAS and BRAF mutational status, which determines predictive and prognostic value. Also, of course, microsatellite unstable versus microsatellite stable tumors. Tumor sidedness, so the location of the primary tumor, still matters in metastatic disease. So metastatic disease derived from left-sided primary tumors behave different than metastatic disease derived from right-sided colorectal cancer. And the division is depicted in this picture is the flexura linealis. That's the difference between left and right-sided colon. Besides these three, which are used in daily practice, there are more novel subgroups which are less often used. For example, amplifications or fusions, so that's mainly HER2 and NTRK. Of course, the tumor microenvironment plays a very big role, and then it's mainly the tumor stroma, but also the immune infiltrate in the tumor, which really determines the behavior of a tumor, but this is not currently used in clinical practice. Well, what the ideal situation would be is that you would have a molecular profile, you know, markers to predict drug sensitivity, to resistance. Ideally, you would also have markers to predict adverse events, so predict toxicity. And then when you combine all these markers, you can go for personalized medicine and really treat patients with the most optimal treatment. Well, we're not here yet, but we are moving to this ultimate goal. Well, if we're talking about biomarkers, you have to realize that there are predictive biomarkers and prognostic biomarkers. And predictive biomarkers can be used to select patients for specific treatments. Prognostic biomarkers can be used to estimate prognosis of patients, but cannot be used to guide treatment decision making. Some biomarkers are, of course, both predictive and prognostic. The most important predictive biomarkers at this moment are mismatch repair status, so microsatellite instability versus stability, RAS and BRAF, and HER2, because these have really implications and they really predict response to treatment. So, as I highlighted before, DNA mutations and amplifications are most predictive of treatment and can be used for treatment decision making with the MSI status. So when we look at subgroups of colorectal cancer, this graph will come back quite some time because I will discuss all of these subgroups. All these subgroups have therapeutic implications, and I will go by them one by one. So first of all, the best group we have, and the best group with the best prognosis are the left-sided RAS BRAF wild-type colorectal cancer. And this group has a specific target. They can be treated with EGFR inhibition, so cetuximab or panitumumab next to the standard chemotherapy and bevacizumab, of course. But the additional treatment option for this group is the EGFR inhibition. In 2007, cetuximab was introduced, and it was first registered for all metastatic colorectal cancer patients. And then we learned that for patients with a RAS mutation, this is not an effective treatment, and patients with a RAS mutation don't benefit from EGFR treatment. In fact, they're even doing worse with EGFR treatment. Sidedness came in 2015. This study showed that right-sided tumors do not benefit from EGFR inhibition in comparison to the left-sided tumors. So we started with all patients, then KRAS mutant ones were excluded. It was extended to other RAS mutations, so NRAS, also BRAF, V600E mutated patients don't benefit from EGFR inhibition, and more recently, right-sided tumors were excluded for this treatment because the benefit is much less. You can fine-tune this even more by looking at other mutations. And Italian groups often study the pressing panel, and the pressing panel is highlighted here. So they look beyond BRAF and RAS mutations, and they look at other mutations in the same pathway, because if that pathway is activated at a different level, this can also lead to resistance to EGFR inhibition. Well, what do they look at? They look at HER2 amplification or activating mutations, MET amplifications, different fusions or rearrangement from NTRK, ROS, ALK, and RET, PI3 kinase, PTEN, and ACT mutations. So they're all in the same signaling pathway. And what you can see in the Kaplan-Meier, so all these patients are RAS, BRAF, wild type. And then you can see one group standing out, so that's the dark blue line. That's the left-sided patients with the pressing panel negative. These patients clearly benefit more from the addition of EGFR inhibition in comparison to right-sided tumors independent of the pressing panel, or left-sided with one of the pressing panel positive. So you can extend your molecular profiling for EGFR inhibition to estimate the benefit. And this is especially important when you want to add it to standard chemotherapy, for example, and you need to decide, am I going to add bevacizumab, or am I going to add cetuximab or panitumumab maybe in first line? Then this can help you in making that decision, because the benefit of EGFR inhibition is much more if next to RAS and BRAF and left-sidedness, also the pressing panel is negative. From the best group, the left-sided wild-type tumors, to the worst group, the group with the poorest prognosis. That's the group with the BRAF V600E mutation. That's approximately 10% of all patients with metastatic colorectal cancer. Well, luckily for this group, we now have a targeted option, which is recently registered in second line. So that's the combination of a BRAF inhibitor and EGFR inhibition. So it's encorafenib with cetuximab. The rationale for this is that you need to inhibit the complete pathway. So the complete MAPK signaling pathway. So these patients have a BRAF mutation, so BRAF is active. For melanoma, for example, inhibition of BRAF is sufficient, but we know that for colorectal cancer, due to reverse signaling, you also need to inhibit upstream, so the EGFR receptor. This was tested in a Beacon trial. In the Beacon trial, these two arms were included, so with either cetuximab and encorafenib, or with the triple, in which also MEK, more downstream, was inhibited by binimetinib. This was published in the New England and also presented at a large meeting. So this is the slide from ASCO. in 2020. So that's the updated overall survival. And what you can see is here the control arm, which was standard of care irinotecan-based chemotherapy, so either irinotecan or FOLFIRI. And when you compare it to the targeted arms, so either the doublet in red, encorafenib cetuximab, or the triplet with binimetinib in blue, you can see a clear advantage in median overall survival with the targeted options compared to the control. There are some things to say about this. The trial was not targeted to evaluate the difference between the doublet and the triplet, but the lines completely overlap. And both second and third line patients were included. So some of the control arm patients had already irinotecan before, so were actually already irinotecan resistant. So this makes the control arm a bit more poorer than if it was a true second line trial. So for progression-free survival, you can see the same. So a clear advantage of the targeted options compared to the control. Because there's no clear difference between the triplet and the doublet is usually used and registered. Another small subgroup, so that's the microsatellite unstable tumors, so that's only 5% of the metastatic colorectal cancers. It's much more frequent in early stage disease, then it's around 15% of the early stage colon cancer, but then it has a good prognosis. But if metastases develop, then the prognosis is usually poor. And the prognosis is poor, but currently, because it's a very predictive marker for immunotherapy, that changes the prognosis of these patients. And currently, this group has improved to being the best group of patients with metastatic colorectal cancer due to the availability of immunotherapy. I will skip this for the time being. The idea, of course, of why microsatellite unstable tumors are sensitive to immunotherapy is that these tumors have a deficient mismatch repair system. So they have a lot of different aberrant proteins, and therefore they can be, in theory, recognized by your immune system. This is inhibited by, for example, PD-L1. And if you add checkpoint inhibition, if you add anti-PD-1, then the T cell can exert their anti-tumor effect. Well, first, this was tested in last line patients, so 3 different trials here in one slide, evaluating immunotherapy for refractory MSI or deficient mismatch repair metastatic colorectal cancer. You can see in last line a very impressive plateau of overall survival of around 60 to 70% for many, many years. Now, luckily, we have the first line randomized trial, the keynote study, which also led to EMA approval of pembrolizumab in first line. In the United States, based on the previous single arm studies, it was already approved for last line, but for EMA, they really demanded a randomized control trial, and then we only have in first line pembrolizumab compared to chemotherapy in the keynote study. Well, as you can see, when you randomize between pembro and standard of care chemotherapy, the first 6 months, there's not a clear difference in progression-free survival, but the difference is made after that 6 months because the response of immunotherapy is very long-lasting, and you see a plateau at around 50% long-term progression-free survival, where with chemotherapy, all patients eventually develop progressive disease. If you look at the anti-tumor response, the response rate don't differ that much, and even the chemotherapy arm does a bit better with regards to primary progressive disease. So 30% of the pembrolizumab patients had primary progressive disease at first evaluation, compared to 12% of the chemotherapy arm. But this does include patients with pseudo-progression, so they will actually benefit, but their first response is progressive disease. Those are the most standard options. Now to a bit more experimental treatment options, but quite well established treatment options for which a lot of phase 2 data exist. So that is HER2 and NTRK. So first I will focus on HER2 positive metastatic colorectal cancer. It is actually also 5% of the metastatic colorectal cancers. That's the same amount as MSI, only we're not used to looking at it that often. So we don't identify this population that much. But if you start looking, you actually see it quite a lot. And then especially in the RAS, BRAF wild type tumors, microsatellite stability, then you can get up to 8% HER2 positivity. Some tumors are already HER2 positive at start. What you can also see is after you treat with anti-EGFR inhibition as a resistance mechanism, HER2 comes up. So what we sometimes do is when a patient has progressed under anti-EGFR treatment, we biopsy again, and then sometimes you find a RAS mutation, but also quite often you find HER2 amplification, and that gives new treatment options for these patients. Also patients who do very poor on anti-EGFR, while they are RAS BRAF wild type, but they do it much shorter than you would expect, then that's really a group to look for HER2 as a mechanism of primary resistance. For HER2, you have the options lapatinib, trastuzumab, or trastuzumab, pertuzumab, and of course it will depend on which trials are open, whether it's possible to give this. In the Netherlands, we have the DRUP trial, so we have access to trastuzumab, pertuzumab continuously for HER2 positive patients. That's all based on phase 2 data. So this is the MyPathway trial evaluating trastuzumab, pertuzumab with the waterfall plot. So you see quite a large group of patients with either a partial response or stable disease. And if you look in the KRAS wild type patients, then you see that quite a lot of patients have actually quite a long progression-free survival. The same is true for lapatinib, trastuzumab. So all these patients received lapatinib, trastuzumab, but what you can see in this Kaplan-Meier is that patients with a high copy number have a much better response to HER2 inhibition than patients with a lower copy number. So you really need a good amplification, of course, for this to work, to be a predictive biomarker for response to HER2 targeted treatment. NTRK is a pan-tumor predictive biomarker for response to larotrectinib or entrectinib. It's very low percentage, so it's less than 1%, and it's especially seen in the microsatellite unstable tumors, and then especially the right-sided microsatellite unstable sporadic tumors, so non-Lynch. In that group, you can find it, but it's very difficult. In the Netherlands, we have done quite a large project in which we have collected tissue from 5 consecutive years of patients with MSI right-sided tumors, because it was the highest chance to find it, and we only found 1 patient in all these samples with an NTRK mutation. So it's questionable how feasible it is to find these patients, but if you find it, then you have a good treatment option. But it will require testing a lot of patients. What's so special about these NTRK fusions? It is only a phase 2 trial, and quite a small phase 2 trial with all different types of tumors, also childhood tumors. And with larotrectinib or entrectinib, there is an impressive progression-free survival seen with a very high chance of response and then a very long progression-free survival. So if you can identify it, it's very beneficial for the patients and it has a clear predictive value, but it's difficult to identify these patients. Of course, it's only single-arm studies, so we don't know what the prognostic value is of NTRK and how these patients would behave without this treatment. So I have discussed the left-sided RAS wild-type patients, which can be treated with anti-EGFR, the HER2 positive patients, BRAF mutated patients, microsatellite unstable, and NTRK. Then we have a very large group of metastatic colorectal cancer patients, RAS mutated. So that's approximately half of all patients with colorectal cancer has a RAS mutation. And we don't have a targeted treatment option for general RAS mutation. So these patients will get chemotherapy plus bevacizumab. But luckily, some news is coming for this group. And for specifically a KRAS G12C mutation. For this group, there's very promising new drugs coming up. For the other RAS mutations, many trials are going on because it's such a big group, but no clear target option yet. I would like to briefly discuss the results for G12C inhibitors, which was presented at last ESMO, so that's the Crystal-1 trial. So when you're looking at KRAS G12C inhibitors, you have sotorasib and you have adagrasib as two selective inhibitors. And at the ESMO in the Crystal trial, adagrasib was used. So it's for colorectal cancer, it's quite a rare KRAS mutation. So only 2 to 4% of the patients with metastatic colorectal cancer have a KRAS G12C mutation. So that's still quite a small subgroup. This group has in general a poor prognosis, but selective inhibitors of this KRAS mutation are available with quite impressive results. So these are the results of a phase 2 trial, and this is the monotherapy arm. So these patients were just treated with adagrasib. These were heavily pre-treated patients, so many of these patients had already 4-5 treatment lines before. So really a refractory population. And what you can see in this waterfall plot is quite an impressive response rate for a single agent in these refractory tumors. So the actually response rate of partial responses was 22%. Stable disease is 64%, leading to a clinical benefit rate of 87%. This is only 45 patients. When you combine it with cetuximab, then you can see that all patients had clinical benefit. So all patients had either stable disease or a partial response, and a response rate of 43%. So nearly half of these patients, of these refractory patients, had a partial response. So it's quite impressive. Many phase 3 trials are going on with both adagrasib or sotorasib, starting from second line already due to these good results. And usually most trials will evaluate the combination with cetuximab, as this clearly improves response rate. So this is really something to look at in your patients. So if they have a RAS mutation, look at the type of RAS mutations, and many phase 3 trials can be found already starting from second line. So that leaves us with these subgroups with specific treatment options. When to test is always the question. So I think for MSI, it's clear. You have a first-line treatment option, pembrolizumab, which is very effective. So this should be tested before you start with first-line treatment. You can test it, of course, in different methods. Different ways. We always use immunohistochemistry. So we test for the mismatch repair proteins, so the presence of these markers. You can also do MSI analysis or an NGS-based analysis. So it will depend on your pathology lab what they would advise. For us, it works well to do it with the immunohistochemistry. RAS and BRAF we also test before first line. We use a gene panel. Not a big gene panel, but our standard is a 50 genes panel, including all RAS mutations, BRAF, ACT, PI3 kinase, some of the pressing genes, not all. I think it's important to test before first line because it's, of course, prognostic. Patients with a BRAF mutation have a much worse prognosis. but also you need it to determine whether you want to add EGFR inhibition or in first line already. Pressing genes, well, are not standard for us to test. We do HER2 and we do some of them. Ideally, you want to be informed as well as possible, I think, before you start anti-EGFR treatment. So if it's possible, I would advise to determine it. Same is true for HER2. For us, it's standard to determine it in RAS-BRAF wild-type patients after second line, because these patients can enter the DRUP program in the Netherlands, so we have a treatment option for these patients. We standardly do immunohistochemistry, like in breast cancer, and if it's 2+ or higher, then we do a FISH confirmation. NFREC we do test in last line, but it's very hard to find. What we do is an immunohistochemistry screening, and if it's positive, then an Archer confirmation to save cost, because immunohistochemistry is quite cheap, and you will pick up most, but you have a lot of false positives, so you need the Archer confirmation. In the Netherlands, there's quite a discussion about what the additive value is of whole genome sequencing. It's absolutely not standard to do, so we only do it in trials. The other discussion is retesting after anti-EGFR treatment. If a patient is fit and is fit enough to enter trials and to continue treatment, we do retest after anti-EGFR treatment. So we retest for RAS, BRAF, and HER2 at least, because these are known resistance mechanisms, and patients can then either go to HER2 targeted therapy, BRAF targeted therapy, or trials against RAS mutation. Let's see. This is quite up to date, although it's a 3-year-old slide. This was a slide from the ESCO educational book in 2018, and it highlighted for which colorectal cancer subtypes we need treatment options for. And I think what stands out most is the RAS mutated group and the PI3 kinase P10 mutated groups, which are 2 large groups, and we don't have any targeted treatment options yet for this group. Below you can see a MET amplification, which is a small group for which in trials you can use MET inhibitors, and I discussed the other ones. So the microenvironment and the CMS classification are not used in clinic yet, and I briefly want to highlight the CMS classification as a novel classification which might have implications in the future, but does not have any predictive value for treatment at this moment. This is not used in standard of care, at least not in the Netherlands, and I don't think it will be standard of care anywhere, because it's also not a very easy test. It's an RNA-based assay, which works best on fresh frozen material. It can be done on fixed material, but then it is slightly more difficult to interpret. It divides colorectal cancer into 4 subgroups based on RNA profiling. And if you have CMS1, which are the microsatellite unstable tumors, usually, BRAF mutations are frequent in this group due to the sporadic MSIs with a high immune infiltrate. CMS2 is a very standard colorectal cancer, so the epithelial phenotype. CMS3 is a metabolic subgroup with quite a lot of RAS mutations, and CMS4 is a mesenchymal subgroup with large stromal infiltration, TGF-beta activation. Depending on the data set evaluated, either the CMS1 patients will have the poorest prognosis, or the CMS4 patients will have the poorest prognosis. And sometimes the CMS3 patients have the poorest prognosis. So that really depends on which article, which population, which stage of disease you look at. CMS2 is in general the best group, with the best chemosensitivity and also response to targeted agents. There's not a predictive value at this moment from CMS. So CMS subtype does not help you in selecting patients for treatment. So CMS1 is the MSI-like. Well, MSI predicts response to immunotherapy, but it's not clear whether you should extend that to CMS1 subtype and whether the MSS CMS1 patients will also respond to immunotherapy. It's likely not. It's likely that you really need the microsatellite instability, and that the other group with the immune infiltrate, but MSS, in that group, immunotherapy alone is not enough. And that perhaps that group can become sensitive to immunotherapy, so it is an interesting group, the MSS CMS1, but it's likely that you need an additional targeted agent to get these patients sensitive to immunotherapy. CMS4, so the stroma group, that's really TGF-beta driven. There are trials going on to evaluate TGF-beta receptor inhibitors, but this group, it's quite difficult to define this group because there's a lot of heterogeneity between metastasis, so you would likely need to biopsy more metastasis to find this subtype and to say this is the predominant subtype. So these trials are running very difficult. CMS3 has no specific drug linked to it, and CMS2 is likely the RAS-BRAF wild-type ones, which responds to anti-EGFR treatment. Another novel biomarker is circulating tumor DNA, so ctDNA. That is DNA shed in the circulation by the tumor. And you can use it in different stages of disease. You can use it in early stage of disease, then it has prognostic value, but you can also use it in a metastatic setting, and then it can have predictive value to detect mutations and to detect the development of resistance. Well, this is highlighted in this graph from Nature Reviews. In the left, you can see early stage cancer, then you can use it, for example, in the screening or early diagnosis of cancer, but also after resecting the primary tumor, the presence of ctDNA leads to detection of residual disease, and you might use it to guide adjuvant treatment, for example, or to guide follow-up strategies. In case of metastatic disease, you can use it for monitoring of response, so you see the ctDNA diminishing in case of response and increasing again in case of recurrence. And you can use it to monitor clonal evolution and the development of resistance. So you can see novel clones or novel mutations coming up in the ctDNA. So it is a very promising biomarker in all stages, but it's currently not used, at least not in the Netherlands, in standard of care for colorectal cancer. For example, for lung cancer, it is used to find new EGFR mutations, but not for colon cancer. This is an example of our own group where we monitor RAS mutations in the blood of patients treated with chemotherapy. So what you can see is before start, quite a high level of RAS mutation was found in the circulating tumor DNA. This decreases when the patients responded to chemotherapy. So it was stable disease and it was undetectable for quite some time. And then here, the CT scans were still stable disease, but you can already see the mutation coming up in the blood. And then here the patients had progressive disease on the CT scan. But what you can see is you can determine the progression earlier on your circulating tumor DNA compared to your radiology. Another novel biomarker, which I work with quite a lot in trials, is organoids. Well, what is an organoid? An organoid is a mini tumor, a living tumor in the lab. So what we do is we take a biopsy of a patient, or we use the resection specimen, and then we culture these 3D mini tumors called organoids in the lab. And you can use them for different purposes. You can use them to mimic the patient in the lab. So that means you can use them as a biomarker for response, because you can test the same treatments you want to treat the patient with in the lab up front. You can determine the response on the organoid, and then it might be used to guide treatment in patients. besides the use for an individual patient, you can use these organoids to develop novel treatment strategies, and you can actually develop or base your novel treatments on what we call patients in the lab. So you capture the heterogeneity, and you can actually do a sort of a trial in the lab already if you have organoids from, for example, 50 patients with the same mutation. You can test whether your novel drug will work on all organoids derived from these 50 patients, or whether there is a subset who is more sensitive to this combination. And if it's sensitive in a high proportion of organoids, this likely predicts a successful trial. Well, one trial we are currently running is the OPTIC trial to really validate the predictive value of organoids for standard of care treatment. So what we are doing is we take a biopsy of a metastasis, we grow the organoids, and we treat the organoids with all standard of care drugs in vitro. The patient is in the meantime treated with physician's choice standard of care therapy. We of course evaluated the response to treatment, and then we can correlate the response of the organoid with the response of the patient. So we can see how well and what is the predictive value of organoids for standard of care treatment. And if this is high enough, the next step would of course be to design a trial in which we want to treat patients organoids based versus physician based, and then see if the progression-free survival, overall survival improves if you treat patients organoid based. So personalization of treatment. Molecular characteristics, as I have discussed in this presentation, are of course very important, and they have predictive value for different treatment types. But it's not the only important thing, of course. You also have the patient characteristics, so the age, the comorbidities, prior treatments, performance status, but also the extent of the tumor burden, tumor sidedness, whether you can achieve a resection of metastasis with downstaging, or whether it's really a palliative treatment, and of course the patient preference, quality of life versus toxicity profiles, and that all combined determines your treatment strategy for each patient individual. A tool we have in the Netherlands to help patients decide on treatment is this decision support tool. This is an English version of it. Normally it's in Dutch, of course, and it's currently being updated with the novel treatments I just discussed are being added, and more information about the molecular status. But it discusses all standard of care treatment options with, in general, the side effects, and you can highlight your preferred treatment options as a doctor. Then the patient can go to the website with a unique login, and they can compare the different treatment options based on type of schedule, type of toxicity, but also expected efficacy. And the program also asks a lot of questions to the patients to help them decide what is important for them. And then a sort of summary rolls out of it from the website, and you can go over that with the patient again, and then together make a decision. Yeah, this is what I told. We're currently updating this, and we are also trying to include a trial mode. So depending on specific characteristics, also trial options within the Netherlands will be included. Last thing I would like to highlight, which can help us in achieving personalized medicine and optimal selection of patients, that is that we need to learn from every patient. So we need to learn from real life data, and not just from the patients treated in trials, because only a fraction of the patients are included in randomized controlled trials. So in the Netherlands, we have the prospective Dutch colorectal cancer cohort, PLCRC. And in this cohort, it's a nationwide cohort, all patients with colorectal cancer are included, and informed consent is asked to collect clinical data, so response data, treatment data, but also baseline characteristics, to use their tissue for research, to obtain up to 10 additional blood samples per year for research. Quality of life questionnaires are included, and many different intervention trials fall under PLCRC. So you already have the basic informed consent of PLCRC, and in your intervention trial, you only have to ask informed consent for the typical additional intervention trials. And you can also use PLCRC to select your patients for these trials. So it started in 2014 in the UMC Utrecht, so only in one center. Currently, it's open in nearly all centers in the Netherlands. Netherlands has around 70 hospitals, and it's open in 63 hospitals now. Currently, nearly 15,000 patients are included in PLCRC, and we have 60 sub-studies. So, to conclude my presentation, I think we have achieved already quite a lot in the last years to more and more personalized treatment for patients with colorectal cancer. We have increased knowledge and increased treatment options for quite some important subgroups, so mainly BRAF mutations, HER2, MSI, and the KRAS G12C are very important treatable subgroups. There is a need for novel targeted options for some other important subgroups, so mainly RAS mutated tumors, but also the CMS4, so the mesenchymal tumors, which in general have quite a poor prognosis and no specific therapy exists. Of course, we would love to have immunotherapy for microsatellite stable tumors to mimic the good responses seen in MSI. So we need predictive biomarkers to optimize selection. We have quite some genomic biomarkers I discussed, such as BRAF, HER2, but that only focus on one mutation. And we know that although you have a BRAF mutation, the response chance to BRAF inhibition with cetuximab is actually still quite small. So there's much more than just these genomic markers. So we need to broaden these biomarkers to optimal select patients. It also means that we need novel trial designs for small subgroups, because this KRAS G12C, that's already only 2% of the metastatic colorectal cancer patients. So when we are narrowing it down, we need different trial designs, and you can't do large randomized trials for very small subgroups. So that's a challenge to design efficient trials. That is what I wanted to present. I'll see if I can stop sharing, maybe. Yeah.